Hello, everyone. So thank you very much for your participation. And now we are opening the webinar on COVID-19 and bioethics with invited lecturer, Professor Disiu Greco, Professor Emeritus Infectious Diseases and Bioethics, Federal University of Minas Gerais in Brazil, to discuss about the recommendation by Brazilian Society of Bioethics. I'm one of the organizers, Professor Chieko Kurihara, a member of COVID-19 Task Force, Japan Association for Bioethics. This webinar is co-organized by Japan Association for Bioethics and the Brazilian Society of Bioethics, for which Professor Greco is a current chair. Professor Greco has been involved in the establishment of Brazil's infectious disease control and bioethics since the time of the HIV crisis in 1980s. And now he is a co-vice chair of UNESCO International Bioethics Committee and engaged in the development of its statement on ethical consideration for COVID-19. Today, we invited Professor Greco to speak about Brazilian recommendation and actual situation in Brazil and also UNESCO statement. His lecture will be about 1 hour, and then we have a short break and we will have 1 hour free discussion. We ask for participants to make your mic and camera off during the time of lecture, and after short break, any one of you can participate in discussion if you speak out your name and then say your opinion or question. Especially, I hope that some of you who met Professor Greco last December can speak. Just say hello, or I hope, or raise difficult debate, which he is willing to accept. Lecture and discussion will be recorded for publication, but we ask for permission of each commentator before publication of the comment. We believe this is a great opportunity to discuss the COVID-19 response from global perspective based on respect and protection of human dignity and human rights in serious, difficult situation common among us. So before starting, two of our organizers will have a brief introduction of this webinar. So first, Professor Eisuke Nakazawa, he is a leader of our COVID-19 task force. And then Dr. Takeo Sayo, a member of our task force. So please, Dr. Nakazawa.
Hi. Nice to meet you, Professor Greco. I'm Eisuke Nakazawa. Thank you. Good morning. Good morning. My name is Eisuke Nakazawa at University of Tokyo. I introduced the Japan Association for Bioethics. Japan Association of Bioethics was launched in 1988, almost 30 years old. It aimed to promote researches on bioethical issues, including research ethics, clinical ethics, and related social issues. Now, about 1,200 members are from all over Japan, now including medical professionals, philosophers, ethicists like me, sociologists, jurists, and so on. It's a very interdisciplinary space. The ethics of COVID-19 task force was authorized by the steering committee of Japan Association of Bioethics this year. That's main purpose is to support our members who will want to research on ethics of COVID-19, providing web resource on the ethical issue of COVID-19, collecting the specialist comments, and holding symposium like this symposium or workshop. Our task force also promotes the members' spontaneous researches. In the annual meeting of the Japan Association for Bioethics held in this December, and especially this year online, we have six symposiums or workshops regarding the ethics of COVID-19. Today, I'm so glad to have this workshop and lecture from Professor Greco. That's a precious opportunity for me and for the Japan Association for Bioethics. Thank you very much.
Oh, thank you very much. So next, Dr. Sayo.
Hello, everyone. Hello, everyone. I'm Dr. Takeo Sayo, practicing internal medicine and psychiatry. Okay. I am very happy to see Professor Greco again. Since last December, we invited him to Tokyo. His lecture was extremely valuable as he achieved equitable access to HIV drug for all who need it in Brazil. It must have been a difficult task for the society just after the democratization of the country. His lectures recording of last December, English versions are available in the journal website. The URL is provided in the leaflet of today's webinar. I hope everyone of you see it. Today, I look forward to your lecture to learn how you struggle with this difficult situation of COVID-19. Okay, thank you.
I'm sorry, there's some kind of howling echo. I'm sorry. So thank you very much. So now we would like to start, and every one of you should make your mic off, please. So thank you very much. So please, Professor Greco, start your lecture.
Okay, thank you, Chieko, Professor Nakazawa, and Takeo for this introduction. I'm going to repeat that I'm very honored again to be in Japan, even virtually. I would like to be there myself instead of at a distance, but that's the way it is now. So I have a difficult task, I think, because it's a very difficult situation for all of us, not as much for Japan, but in Brazil, we're living hard times. But I'm going to try to go through what we have done, and I'm going to give you a picture of how things are going to be, are being discussed and what's going to happen, we hope, in the end of this pandemic. So that's the title, you know about that. I'm going to be dealing more specifically with the recommendation, but I'm going to talk a little bit more, and I hope that during the discussion, we'll have time and the possibility of exchanging our views. And I think it's going to be very interesting because as Professor Nakazawa said, and he said, your association was started in 1988. The Brazilian Society of Bioethics is from 1995. We have a little bit more of members, but of course, the country is a little bit larger, but it's a complicated situation for all of us in these times of difficulties. And what let's see if I can make it move, yes. Well, the summary of what I'm going to say is there. Recommendation, the situation of the COVID pandemic in Brazil and Japan, and an overview of COVID candidates vaccines. I showed this slide before to you. That's where I am in Belo Horizonte, in the southeast of Brazil, a city of 3 million people, maybe the 4th largest city in Brazil. And we're a little bit far away. I think it's about 19,000 kilometers. And you can see there, and I'm not going to go through all of this, but just to tell you, we have 210 million inhabitants, and a lot of them living in a very difficult situation on less than $2 a day. It's more than that now. It was 10.8, that was before the pandemic. Of course, Japan, you know, is completely different. And sorry. Okay, so I'm not going to show you this, but it's going to be my slide that you can use if you need. It's very interesting to see what happened with this pandemic because it's very recent. If you think of it, it's in December 2019. It started in Wuhan. And very coincidentally, we were in China this time. When I left Japan, we spent about 13 days in China. Probably the virus was already circulating. And I came back to Brazil with a terrible cold. We didn't know what it was. Looking retrospectively, I thought I could have been infected at that time, but I did all the tests. It was not COVID, it was something else, but it was very bad. And it's very interesting to remember that there's a very good book on the plague, Alberto Camus, 1947. And he said a very interesting thing. Plagues and wars have always happened in human history, but both always take the population by surprise. And that's very true. And if you look back in these last 100 years, how many epidemics did we have? And all the time we are surprised. We should not be surprised by that because we are going to have some other coming, of course. And it's very interesting, the coincidence. In the plague, they had a fictitious city that was Wuhan, and in China was Wuhan. It's just a coincidence. I think it's interesting. And I'm going to give you an overview of Brazil. That's a recent map of the notification of COVID cases in Brazil. You can see it's a big country. It's concentrated in the south and the southeast, and the northeast where most of people live. But we have cases throughout the country. And different from HIV, it spread much faster because it's easier to spread by air. So that's how Brazil is now, with cases everywhere. And I think this is a very interesting comparison, especially the dates. Be aware that I'm talking about August the 3rd. Total cases, 17 million cases in the world with 680,000 deaths. If we go back to yesterday, it's double the number of cases, and it's almost double the number of deaths. And the number of cases per day of death is not very different from a few months ago. We may think that's a little bit of stabilizing, a little bit less than it was in August. And if you look in Brazil, in the United States, it's the same. 4 million cases in August, 8 million, almost double 2.5 months later. The death rate increased from 153,000 to 218. And it seems that it's a little bit stabilized, still with a lot of deaths per day. And then if you get to Brazil, we had 2,700,000 cases. It doubled almost again in this very short time, with over 150,000 deaths. That's a lot if you think about it. It's many cases. But one thing that people are a little bit more optimistic is that we had about 1,000 cases per day at that time, and the last 2 weeks, it's less than 400. It's still a lot, but it's less than it was before. And if you get to Japan, that's a very good experience because you have, as of October, yesterday, 93,000 cases. And just to remind us that you have half the population of Brazil, but if you see how many cases did you have, and if you compare to Japan, you are doing a very good job. With 1,600 cases of death, the difference is amazing. And I think the last count that I did yesterday was 3 deaths in a day. In Canada, I just thought to put it because I thought Lynette would be present. It's very much different from their neighbor in the United States, much less. And yesterday, 118 cases. The point is that if you look at this picture, it seems that in many ways, COVID may be a little bit in the way of controlling. But if you look what's happening in Europe today, it's increasing everywhere. So we really don't know what's going to happen number-wise and how this epidemic is going to maintain its spread throughout the world. And many people hope that the vaccine would change that. But that's another difficult thing that we can discuss a little bit during our discussion. There are some selected facts that it will be interesting to say, because the death rate is apparently low. But with this number of cases, even if the death rate is low, the number of cases, the sheer number of cases is very high. And that's for Brazil, October 20, more than 150,000 cases. And of course, we all know affects disproportionately the elder, but much more intensely in people that are most socially vulnerable. I put just an examples here, but that's very important to all of us, including to discuss access to care, because the social determinants of health are exactly here. And that's a point that we have to discuss very thoroughly. And more important of all now, there's no pharmacological treatment that has shown to be effective. Well, we have one, the dexamethasone, but just specifically for very, very grave situations. We need to keep physical isolation and not social isolation, because as we can see today, social, we are much closer, because I wouldn't be able to be in Japan in normal situations just to give a talk again, but now we can do it. It's easy for us to be in many places almost at the same time. A thing that Brazil has been doing for a long time, and Canada has the same, is the reinforcement of a comprehensive, inclusive, free for all universal health system. I think that's the most important thing, and COVID is showing that to us. And this is my feeling that it's very much unlikely that we're going to have a magic bullet to control the pandemic. Many people think that vaccine is going to be there, but there are many obstacles to that. And many proposals. I shouldn't put it here, maybe in the end, but many proposals. We have to establish clear, ethical, and transparent rules for coping with the various aspects. Respect human rights and dignity of the population at risk and affected. I think that's going to be my mantra. I'm going to repeat that all the time here. Increase financing for health and education. That is needed everywhere. I think even in Japan, especially in the situation that's most happening in the world, to tackle the social determinants of health. That of course, this pandemic affects exactly this population. And reinforce for the population the essential role of a truly universal health system. And of course, emphasizing the importance of primary care for confrontation. And the thing that happened with HIV/AIDS, and I don't think that's very much yet in Brazil, is that the civil society must be involved, because they need to emancipate to fight for their rights. And the other thing that in Brazil is very important with all this fake news and infodemia is we need to accentuate the role of science that should be adequately financed for the control of this pandemic. Of course, we have many ethical guidelines to think about. And I'm going to show just some of them. The one that I have been using a lot, and I think most of you know very well, I don't even have to go through, is the Universal Declaration of Bioethics and Human Rights of UNESCO in 2005, that in many places says about what I'm saying that people without distinction should benefit from the same high standards in medicine and life science research. And the aim of the declaration is to promote respect for human dignity and protect human rights. All the things that are here, I think it's very hard to think that some people can be against that. I think the main problem is how do we enforce it in a good way that people can use that as a part of their fight for their emancipation, for having their rights. The Article 3 talks about human dignity and human rights. Again, human dignity, human rights, and fundamental freedoms are to be fully respected. And social responsibility, saying that progress in science and technology should advance, and number one is access to quality healthcare and essential medicine. So it's written there. That's much before the COVID pandemic. But again, how do we enforce that in a better way. And other ones, sharing of benefits, of course, people should share whatever benefits from scientific research. The decision-making and addressing bioethical issues with professionalism, honesty, integrity, and transparency in decision-making should be promoted. It's very interesting, and I have been participating in many of this. I did not participate in this one, but I like much more when you use the English word to use must instead of should. Even in Portuguese, there's not that much distinction, but in English, yes. Should is you expect to, and must, it has to be done. So I think that's a point that maybe in the discussion, the declaration, they could not get to a different word than that. And then I get to the Brazilian Society of Bioethics Recommendation 1/2020. You had access to that, maybe some people read it, and maybe what I'm going to do here is repeating some of the things that are there, but I think it'd be interesting to stress what we try to do with this recommendation that is from just maybe 2 or 3 months in the epidemic in Brazil. And the recommendation says about respect for and protection of human dignity and human rights, aiming at assuring equalitarian access to healthcare and public health emergencies. Of course, if you be very critical, so, but everything is written everywhere. But we thought it would be interesting to have something that's Brazilian, that comes from Brazilian Society of Bioethics, that's our co-sister in Japan. We started the society in 1995, it's 25 years now, and it's very important to have as a place where people can get some answer or get something that they can use. And I know that in Brazil now, even the judiciary system sometimes is using a recommendation to decide things about the COVID. It addresses fundamentals and ethical aspects of the pandemic in Brazil, but many of the things that are here can be universal. Here is very specific to Brazil, advocates the protection of the most vulnerable and the indispensability of the unified health system, that's its name is SUS in Brazil, and the right to access to best treatment for all and equal access to all ICU. And then in Brazil, it's important, both public and private. And that's going to be just a side talk. We have the same number of public ICU beds as we have of private. But private, the access is only for 25% of the population. And public is for 75%, of where all people can have access. So it would be very important to have this access to all and not separating public and private in this situation. And of course, it recommends parameters to be followed in the situation that we don't expect to have, and we hope it does not happen, of insufficiency of this. And there are many things. I think there's a slide with all this writing is very hard to follow. But it's my duty here to go through with you at least some of this. And with all the considerings of the Brazilian Society of Bioethics, we recommended that in decision-making for the allocation of health research and technology, at the current stage of the COVID pandemic, the constitutional principle of human dignity and human solidarity, attaching to bioethics principles, especially those mentioned above, are respected and must include that. Decision on research allocation ensures the right of all patients, and not only those infected, but those at risk of being infected, because if we give this research allocation in that situation, we're going to have much less chances of having insufficiency of ICU beds. And in Brazil, of course, the financing, I mentioned that, is needed to be expanded. We are living a very bad situation of a cap in health and education expenditure based on the last government. It's almost impossible to think that in a country that is getting older, getting more people, that you cannot expand the financing. there was a question that I received. The state use available ethical and legal instruments to ensure price policy and conditions for medicines. We were short of putting something, but was not a consensus. And that was another question that came in the mail, is that we should have put that the Brazilian Society of Bioethics should be on side of those that think that anything that's developed for COVID should not be patented, should be out of patent, should be access to all. We didn't put that in our recommendation, but the Brazilian Society of Bioethics has this in their main discussions today. Preventive measures, again, I think that's very important because that's the way of maybe avoiding what's happening in Europe now. They open too much, and then we're going to have a lot of cases again, very precautious, and they are going to have problem in dealing with that. And patients' rights, including equal access, are guaranteed to all levels of care. And here we stress that primary care, intermediate care, is probably more important than thinking just to talk about intensive and special intensive care. Because if we make it very good access to primary care, to intermediate care, maybe we're not going to need a lot of intensive care beds as we're expecting to have in many places. Here I mentioned that already. Let's see, let me go back. Yeah, 6. All intensive care beds should be regulated by just the public health. That's what I mentioned before. Equity must be ensured. All mechanisms should be in place to ensure secrecy and confidentiality. That's a big discussion today because people think that in situation of pandemic, you can open everything to everyone. That's not true. We have to be very clear on that, very careful on that, to avoid more discrimination. And of course, opening confidentiality is very bad. And information provided to society, that's the thing that we have problems because with all the fake news, we have to be sure that the information that at least we scientists and bioethicists that we provide to the population is what we have in science. But what's happening is almost the opposite because with all this spread of news about new medication, new magic treatments, and people saying that especially in Brazil, that the pandemic is not a problem, it's just another flu. It's very bad for all of us. Of course, appropriate number of health professionals, ancillary service. And this happened in Brazil. We put here very clear that new drugs or off-label use may be only permitted in the course of research duly approved by the Research Ethics Committee. And maybe, of course, through compassionate access situation, but that's very exceptional. Instead of saying, well, I did with 3 patients, they got better, now I can use to everyone, and that's not true, and we have to go against that. When, even after the location of all private and public ICU beds to our public health system, they are insufficient, the establishment of flow chart based on scientific knowledge for their occupation by patients who need them is evaluating this discussion. And there's another question that's very important to all of us, is about hospital bioethics commissions. And Brazil in 2015 had the first recommendation from the Brazilian Medical Council asking all hospitals to have in place, or just asking, was not a determination, to have a bioethics commission. But unfortunately, up to now, we don't have that many. And in this aspect, I think I answered a little bit what they have asked, is that our next annual meeting, biannual meeting, is going to be in October next year. And it's going to be the first Congress that's going to be on bioethics, hospital bioethics commissions. So we're expecting to join people together to establish in everywhere, and we need that very much. So what happens today, what happens today is that as we don't have that, the decision is being made by people that are taking care of the patients that are in need. In decision-making and treatment of bioethics issues, including dilemmas and situations of insufficiency, we, we stated that these committees, if they are established, apply principles of the Universal Declaration of Bioethics and Human Rights and consider 3 points: professionalism, honesty, integrity, and transparency. Individuals and professionals involved shall be regularly included in the common process of dialogue, and opportunities should be promoted for the pluralist public debate, seeking to express all relevant opinions. If we don't have the Bioethics Commission, this is being done in each hospital with the expectation that people are going to, to have enough individuals from their own hospitals that have experience both in clinical issues and in bioethics issues. And that's, I think, one of the most important is here. Be assured that at the end of the pandemic, that we have to end, there will be needed investment in public health system, research and training, and expansion of the number of professional research in all those activities in Brazil. And last, I think that's almost the last, in decision-making allocation of needed health resource and technology with the objective of establishing criteria for prioritization of access, the bioethical, dignity and human rights principles must, it's not should, be respected. And we end with this flowchart that hopes that with this flowchart for establishing ethical criteria for all who need them is based on validated scientific knowledge, ensuring absolute respect to ethical principles, fundamental rights, and human dignity without discrimination of any nature or any factor not related to the health condition. That's a kind of against that first thought of many people that you should save the younger and leave the old to their own fate. We're against that. We think it should be discussed in a different way. And the flowchart shows that. I'm not going to go through, but there's one point I'm going to stress. It's because when you decide to do a recommendation, the pressure was exactly on the ICU beds. And we decided in our discussion that that's just the last point, the last step of taking care of people. So we decided to start with a symptomatic individual in the first time that he thinks that he may be infected. And this is the most important place. And then we have to have a timely and egalitarian access to care. And then it follow-ups many things. Access severity, if it needs intensive care, look if you have beds. If you don't have beds, then you follow a difficult situation. But we try to make it in a way that it does not go against anything that we mentioned up here. Ethical principles, fundamental rights, and human dignity. But we can discuss it further during the second part of the discussion. But what I mentioned in the beginning, I use that very much all the time. I mentioned this phrase by Norbert Bobbio, that died about 10 years ago in this Fundamentals of Human Rights of 1964. He said, and it applies very well today, that the gravest problem of our times in relation to human rights is not anymore to set its foundations. Everything is written. You can go back to 1945 with the International Declaration for Human Rights and get all the documents that we need, but the problem is to protect them, to make them really, really work. I hope this in Japanese, it's almost what I think it's here, but then you tell me later and I'll correct next time we talk about it. I'm going to switch a little bit to the vaccines. I think it's important because it has been discussed everywhere. And about a month ago, I was invited to participate in the WHO ACT Accelerator for Bioethics with many people from the world, including from Canada, from the United States, a lot of people from India, some from Africa, and we are discussing with them what's going to happen to access to candidate COVID vaccine. And I saw in the question that you sent to me that Japan is using, because of course we are not going to have any pressure to have the vaccine there for emergency situation. We're going to use probably exactly what you do for influenza. Get the elderly, get the most affected, get the healthcare professionals. And I think that's a good way of thinking about what we can do. There are many vaccines on trial, and I thank Chieko for sending me her paper that has much more than we have here. But that's just a very, that was, I think I found this yesterday. The number of vaccines that are in different phases, 11 are in phase 3. Limited disposition, there are 6 for specific situations in China, in Russia, and none of them is already approved. So we need a lot of things before leaving phase 3 and get it approved for all use. And Brazil is testing a lot of them for many reasons, of course, because we have a very established research environment. We have 2 big laboratories that produce vaccine for many years, including the largest production of yellow fever vaccine is made in Brazil. And of course, we have a lot of people in need, in danger of being infected. So we have at least 4 of them from Oxford, from Sinovac, the Chinese, from Pfizer Wyeth, and from Janssen Silag. I don't know which one of these is Johnson Johnson. Maybe there's another one. I'm not going to confuse myself with that. And WHO decided to use this. They have a group of people with goals and principles for the COVID vaccine for the world that's very different from one country or the other. And it's interesting because they decided that the overarching goal is that vaccine must be a global public good, and expecting that it can contribute significantly to the equitable protection and promotion of human well-being around the world. That's very important because, and I have discussed that with people that are responsible including for preparing this, all these principles, is that I asked about if it would be nice to have a definition that no patent could be provided for all of this. And they said pragmatically that that may be impossible. I'm not sure if it's impossible. That's what they said. And what they decided to do was to join many countries to have money to buy vaccines to distribute to everywhere. I'm not going to go through this, but just to remember that there are many principles. Human well-being, equal respect, equity, that's very important. National equity, that I think that's impossible to decide from WHO. Reciprocity and legitimacy. I think that's the principles are very interesting. And the COVAX, that's what I was mentioning, they are getting countries to be involved in their activities. And I'm not sure the date of that, but they had about 150 countries already involved in activities seeking global, equitable, and fair access. What they decided to do was to get countries that are richer. At this time, had 75 countries that would finance vaccine for their own budget, and then partner with 90 countries with low income that would be financed through voluntary donations to Gavi, to the COVAX Advanced Market Commitment. So that's pragmatic. If you could get a lot of countries here to participate, buying vaccines, putting money, we could help the other countries. That's the way they think that could be pragmatic and more realistic in their way of seeing it. But it's very interesting. At that time, I'm not sure what happened. Yeah, at this time was 165 countries, represent approximately 60% of the world population. At this time, they were absent: the United States, the European Union, China, and Russia. So the main actors up to this time they are not participating. So that's a problem to all of us, because these people in the United States, European Union, China, and Russia are going to need a lot of vaccine. And I'm not sure how it's going to be this fair access imposed, or at least being possible. This from the same thing, the COVID tools accelerator, they call the ACT Accelerator. According to them, that's propaganda from them. It's a groundbreaking global collaboration to accelerate the development, production, and equitable access to COVID tests, treatments, and vaccines. It's very interesting because I'm not saying only about vaccines. They want to have the test available. That's very important to all of us, to test people. Treatments if they are developed, and of course vaccines. And they involve the Gavi, that's very important. CEPI, that's a Coalition for Epidemic Preparedness Innovations, and WHO. The pillar of vaccine of the ACT Accelerator, convened by CEPI, Gavi, and WHO, is speeding up the search for an effective vaccine for all countries. They expect to have 2 billion doses that can be fairly distributed by the end of 2021. That's very optimistic, but I think we should aim together to have that. And then the pragmatic thing about it, and that's a discussion that we're having, and it goes against many things that have been written. They expect to have the certainty that at least 20% of countries' population will have access in the phase one. Phase one not of the vaccine, phase one of this process, which is interesting because with 20% of countries' population are going to access, most of the people are in need. And what they mentioned and they said is that if they don't include all countries, and not only the most in need, they're not going to be able to bring together the countries that have more money. So maybe that's pragmatic, and I tend to agree in a way with this, but it can be discussed between us. I'll finish with equity, and I mentioned that when I was in Japan last year. And I think the same that we have, Canada is the same, I think England has the same way. Many countries have, but these examples I tend to use very, very frequently. That is the access to universal health care. And what I mean by universal health care is not coverage. Is to be access free of charge with integrality to all people that need it. Because if you have coverage, but people cannot pay for the coverage, it's almost the same as not having it. And this is in our constitution. Takeo mentioned about the response to HIV that was around this time, 1988. And for people that do not know it, but Brazil faced a terrible dictatorship that from 1964 to 1985. So that was the first new constitution, just 3 years after we democratized again, in sorts, Brazil. And it's interesting because with this article, 196, it's stated in the constitution that health is a right of all and a duty of the state. And the second part of this phrase is saying that it needs a lot of things to guarantee this. And this was exactly what happened with the foundation of the unified health system. That's in Article 198 of the same constitution, saying that shall be financed with funds of the social welfare budget of the union, states, and the federal districts, as well as from other sources. It says that everything in the system is going to be paid with public monies, and that's important. And it's amazing what the system in a country that's so disparate with all this, everything bad that you can say about Brazil, we have examples. But this system, in numbers, it's amazing. They have 30,000 family health teams, spread to the country. That's primary care. I think that's the most important probably thing of the unified health system. And unfortunately, with the right-wing government now, they are underfinanced. We have 8,500 public hospitals with 5,100 beds, many emergency facilities. And this is what 3/4 of the population are as only one access to care. Of course, everyone can have access to it, but maybe now it's a little bit less than 40 million people have their private plans. And the dimensions are very amazing too. It's the largest network of human milk bank. It's the world's largest number of organ transplants is done at SUS. It funds 90% of preventive vaccines. It funds 80% of all treatments on oncology. And this is very important. Another thing that I participated very intensively since the beginning of the epidemic. All antiretroviral drugs and lab exams are funded by SUS. You cannot buy it. Everything is provided by the federal government, including hepatitis treatment. Now with the new treatment, everything is included. People can be assessed. And this is important too, 90% of total hemodialysis in the country is made through the SUS. But some things affect, and I think one thing that we are getting, this is from World Mapper, this research and development expenditure. It's very interesting to see Brazil is very thin. And if you look, Japan is here, Europe, a lot in India, and especially in the North America. That's a very important thing to have. We have to have research and development expenditure to make those things happen. But not only this, I didn't put the slide now, but it's exactly the same with access to funds for health and education. And then in conclusion, another slide that's not very didactic is specifically the role of bioethics in emergency situations, especially in the COVID pandemic. Access to adequate health care at all levels, part of several international documents and conventions in which most countries participated in its establishment and approved them. Examples I have given: the Universal Declaration of Human Rights, 1945, 46, 47, 45, and 2005 UNESCO's. And many things are pre-pandemic. I think that's the most important thing for all of us to think about and discuss. Because especially in Brazil, and I think it's repeated in many countries, what we're seeing now is nothing new. The epidemic just denuded, opened up for everyone to see the disparities. And I'm not sure what's happening in Japan, but poverty is all over. So it affects intensively. And I'm going to talk about that again. I mentioned that in the beginning, the social determinants of health, which include but are not limited to situations that affect physical and mental health access to adequate education, sanitation, access to quality water, food, etc. These circumstances that reach a significant portion of the world population, Brazil is a very large portion of the population, are accentuated by the uneven distribution of income, unequal distribution of income, power and resources, both locally and globally, and are the framework for situations of increased vulnerability in marginalized populations. I'm going to name them. Among them, the poor, the unemployed, and underemployed, Blacks, women, people living on the streets, people deprived of liberty. That's amazing. In Brazil, we have 750,000 people deprived of liberty. I think we're the second and the third in the world. Of course, the United States is the first. With mental suffering, residents in slums and outskirts of large cities, the LGBTQI+ population, with inadequate access to everything, including public health service. Singer, I think it was, of course, was Singer that mentioned and described it as a syndemia. I think it's important to use that in this situation. And she was talking about the relationship between drug abuse, violence, and the AIDS epidemic. She called this three condition a unique union that puts together the social determinants of health and the specific happenings in the health of many people. Then all the pre-existing conditions of injustice and inequality interact synergistically and negatively on individual and population health. Of course, in the specific, but it's not exclusive to COVID-19. And of course, again, it's worth emphasizing that controlling chronic non-communicable disease, and most of that, more than that, the social background of vulnerability are prerequisites for effective control of the current epidemic. In Brazil, it's amazing how things are, because if we look here, the social and health situation, the majority of the population was intolerable before the epidemic. And in 2019, extreme poverty already reached 13.5 million people, surviving with up to $1.9 per day. It's incredible. It's impossible to survive on that. And these numbers are growing. It was going down during the presidency of Lula, that was some years ago, but it was already going up. And since 2014, 4.5 million have fallen to the level of extreme poverty. So it's intolerable. That's the point. And of course, other roles for the bioethics in research and public health includes the discussion on access to care and treatment. That, in my opinion, is outdated in relation to research, because the debates now is not how we are going to have people access during the time they are on research, but it's how do we objectively provide access to all efficacious products of research and public health. And universal access to current, established, and future research products must be international sanctioned and enforced through international covenants and resolutions issued by the United Nations. What I mean is that the status quo of inequality must not be an immutable fact, and we must fight for universal access to health. Of course, I'm contradicting myself, because I'm asking for more resolutions. But I think that what we need now is, like, as Bobbio said, is that we have to enforce what we have. And last but not least, we must be prepared for upcoming ethical challenges. The COVID pandemic is just one example, because that's not the last one. It was not the first one, it's not the last one. Maybe many people are going to be just relieved when a vaccine or something else comes by and said, oh, I can go back to the normal. I have been repeating, and the Brazilian Society of Bioethics repeats that, it was not normal before. It was awful. We hope we don't get back to that normal. We have to maybe use this opportunity. That's a kind of wishful thinking, but I think it's possible to make things different, to make people decide what they need and how do they need. And I'll finish. I conclude with one quotation and a tribute. This quotation, if you were in my talk in December, I used the same one, was Thucydides in the Peloponnesian Wars that said that justice will come only when those who are not subjected to injustice are as indignant as those who are. I think we all of us that are here, we are in this situation. We're not that much subjected to injustice, but we are indignant. But I don't think that's enough. My opinion, and I'm being bold to say that my opinion, not against Thucydides, but changing Thucydides, is that justice will prevail when those affected and indignant by injustice are able to fight for their rights. And this many people call empowerment. Empowerment of course, is an English word. In Portuguese, it has been translated directly. And it's used many times, not as I am empowered. It says, I'm going to empower you. I don't think that ever happens. I like what Paulo Freire mentioned many times, and I call it emancipation. People have to emancipate to fight for their rights and not expect someone to empower them. And my tribute is to England. It's interesting because that was 2012, the opening ceremony of the Winter Games. And what they used as the main motto was the national health system. And those who were there, sitting here as part of this opening, were the nurses from the NIH and HS. And I think that's amazing. I think that's a thing that we should do everywhere. And very recently, one airline company in the United Kingdom did that too. Thank you, National Health System. I thank you for your attention. Arigato. Muito obrigado. That's the logo of the Brazilian Society of Bioethics, and that's the address. There's some things in English. And if you need to talk to me, my email address is there.
Trabalhar bastante. Então, desejo uma ótima reunião para vocês. Prazer em conhecer vocês todos.
I finish here, and I give back the floor to Chico. I think I made exactly on time. You said 1 hour, and I did it in 50 minutes. I think it was a little bit too much, but I'm sorry for that.
No, thank you very much. Thank you very much for your valuable lecture. So last December, you gave the lecture on your achievement. It's great. It's amazing because Brazil is a very much relatively resource limited country, and you achieved the equitable universal access to healthcare for all who need it. And now you're still now struggling for this same aim to achieve human dignity and human right. The health is right of all the people who need it. Yeah. So I respect your struggle so much.
Let me interrupt you in this part because I think it's very interesting. When we look back what happened in 1996, specifically when Brazil decided to give antiretroviral treatment to everyone, we were dealing with many difficult situations. The economic situation was bad, but the decision was political. We did everything rightly. We had involvement from the government, we have involvement from civil society. We financed a lot of research from NGOs, and we had the national health system working properly. And now with COVID, that we should have used this example to tackle, we're using exactly the opposite. The government got in very late with denying the problems with the severity of COVID, and they are not financing properly our national health system. So it's very interesting if you look historically. We had everything in place in 1996. We still have the things in place now, but we have not been able as a country to control this epidemic. Thank you.
Yeah, thank you very much. So I'm sorry if it is possible. I called the names of some persons, but I would like to ask for every one of you to have participate in this discussion session. And if you say your name and say your opinion or discussion, and everyone, we welcome to participate in the discussion. And is it, for the first time, is it possible for Professor Kimura to ask for your comment or question? Oh.
Hello. Muito obrigado.
De nada. Arigato.
Well, I'm so glad to see you here by Zoom from Brazil. It's really fascinating talk which I have heard from you. Thank you very much. Obrigado. Muito obrigado.
Thank you.
I was very much impressed by your final comment by quoting Thucydides. What he was a famous historian. So your analysis based on such a long time span, including Greek historian, I was very much impressed by your comments for today. One of the, my first question is very a concrete question. Maybe this is for you. This became very clear for you. One of the things is just yesterday there was an article in the newspaper in Tokyo about the sudden death of the young physician in Brazil who are in the clinical trial of AstraZeneca. And he was taking placebo, but he died. Is it really true? That was my small question at the beginning.
Yes, it's nice to hear you because I cannot see you, but very nice to have you.
Yes.
You have so many, and you could even say a little bit about Paulo Freire too, because you met him many times. But yes, this was a sudden death of a participant. And they, at least what they released was that he was on the placebo group, so not related.
He was in the placebo group?
Yes, yeah, that's what is said in our newspaper too. I think it should be true. I don't think they would be able to skip that because they had to open, of course, they had to open, the DSMB had to open the trial to see what was he getting.
I see.
But that's an important thing that you mentioned because we don't know what's going to happen with these vaccines.
Yeah.
One of them was stopped because of another side effect that was related to the vaccine. But I think it's very soon to say that we're going to have a vaccine ready in the next few months. But let's see. Let's hope and something happens different from what I'm saying.
Yeah. But your country is very active for thinking to have the clinical trial of the AstraZeneca. Very much. You are very eager to have vaccine, right?
I think everyone is. I think what I mentioned about magic bullet.
Yeah.
People are expecting that everything is going to be back to normal. That's not very true because, of course, maybe and of course, almost true that this infection is going to linger on for a long time, and it's going to still affecting the people that are more in need. Because for us, I mean, I'm staying away from risk for the last 5 months, but people that need to work, they're working back and they're going to be exposed. So it's going to be a hard time, especially for us here. Japan, luckily, you are in a situation that's different, but you are affected also because we are the world, right?
Yes, yeah. Well, thank you very much. Maybe some other person have some questions.
Good to see you. You look younger than last time I saw you.
Thank you. You look so nice. Thank you very much indeed. Yes, we have got a very good, nice magazine, including your photos and the presentations on Paulo Freire and so on, edited by Ms. Kurihara. It's a very interesting journal.
But you promised me something.
Yes.
You promised to send me one of your plays that you said you're.
Yes, I do. Yes.
I didn't forget it.
I will do that. Yes.
Thank you.
Thank you very much indeed.
Thank you very much. So next, can I call Lynette to ask for your comment or question or anything you like? Thank you.
Hi. Hello, we got our power back. My power was out here. We didn't have any power. Our infrastructure was down just before the session started, but it came back on. I very much appreciated hearing your talk, Professor Greco. It was wonderful demonstration of the strength of approaching health issues from a human rights perspective and keeping that in mind. Chico has referred to in the Journal of Medical Ethics early in the pandemic, or I was writing and working on it. And maybe I'll just say a little bit about that for the rest of the audience as a frame for asking a question. What I had noted was that North American bioethicists in particular, but also some maybe bioethicists in the Anglo-American tradition, so also British bioethicists and critical care society triage authors, and were publishing statements, or as it were prefacing their recommendations for critical care triage in a pandemic with the claim that it was universally agreed that utility, that maximizing outcomes had to be the principle governing, that took precedence in governing these kinds of triage decisions, with a reference to warfare, wartime triage. And that seemed an unusual claim to me because bioethicists, of course, like to argue and disagree about fundamental points and not just make tidy consensus.
It's true.
Fundamental points. And we recognize as bioethicists, I hope, that societal values come into play and that these issues are not settled so simply. So I wrote this article that drawing comparison to health technology assessment resource allocation, where multiple values are brought into play and the goal of maximizing utility and its shortcomings are well known, but also in organ allocation, where there might be a criteria that would maximize outcomes in terms of lives saved or life years saved, but that would disproportionately affect a vulnerable group given the social determinants of health or given processes of racialization and racism in a given nation, for example. So in these other areas of allocation of resources that are directly life-saving in organ allocation, or that, you know, if you look at the big picture, there's still lives at stake in other kinds of resource allocation. We don't just agree that we have to maximize outcomes. We recognize that there are problems in maximizing outcomes, that you'll end up giving your resources disproportionately to the people who are most likely to benefit from them, which are going to be the people who have experienced the best social determinants of health, the social determinants of health that are going to make them most robust to be able to benefit from medical intervention. And in a pandemic like this would be especially problematic because of us who enjoy good social determinants of health are able to work from home, isolate ourselves from exposure, and people who we rely on to keep the infrastructure going and keep everybody with the provisions they need and so on are in a more precarious economy where they're not able to do those kinds of things. So they're going to be both the most the most vulnerable to infection, and then the least robust to survive infection if they are infected potentially, right? So it becomes important in this environment, was my argument, to really articulate fundamental social justice concerns, which I see in your Brazilian process you have done. I mean, most specifically and obviously, you've adopted discharge, survival to discharge, and not overall life years, for example, as a valid measure in criteria in triage, whereas maybe in North America and in the UK and English-speaking Europe, an emphasis is now to say, well, since we've agreed that we're maximizing outcomes, let's agree how far we want to push maximizing outcomes. So the next discussion is life years, or maybe life stages, or other kinds of things that will privilege the young and healthy. That was one concern I had, was just the disproportionate burden and the social determinants of health. And the other was that we have existing commitments in society to distribute resources, as it were, less efficiently, where we might save fewer lives, but where we're fulfilling important obligations of respecting human rights and enabling disabled persons, and for the elderly, you could say, also for older adults as a stigmatized group who might be disadvantaged, as we've seen in many European countries. And I come from a jurisdiction where 90% of our cases were in long-term care facilities. So we really had a severe problem that in our attempt to protect the critical care resources of our hospitals, many people were discharged to long-term care facilities, and they were kept in long-term care facilities. So when people in long-term care had COVID, they were not taken back to the hospital, and those facilities became overcrowded. And in our province, 90% of COVID deaths were in long-term care, which is, I think, leads the world, if you could say, or comes out bottom in the world in that measure. So that's the background for people who haven't read the paper and know why Chico was referring to this invitation. So I'm interested to hear in your discussions. I think we talk about sometimes medical criteria versus ethical criteria or human rights criteria. And I think you would know that in the detail of medical criteria, of course, are hidden, or don't want to say hidden, but medical criteria just means things that you can measure medically, right? With some reference possibly to potential to survive, or some reference possibly to potential to survive without the intervention, or some reference to degree of need, just suffering, acuity kind of claim. So I'm interested in what observations you have about the different ethical criteria that can be implicit in the medical criteria you use in triage, and what kind of conversation you had about that. And then also the idea, I know it's ethicists who think about this, come to the idea that actually randomization and wait lists are not that bad ethically, because one thing they do not do is persons. They're kind of a that kind of randomization of access and scarce resources is a way of our saying we recognize that everybody's claim here is equal, and we don't actually have a criteria on which we think we can decide life and death. So we might as well use a random process, which might be the time of presentation. That's not very perfectly random, or we might use lottery. And when you reason it through, it sounds very plausible, but I think maybe the public doesn't like the idea, or even professionals don't like the idea of gambling with life, of having a random process actually decide life and death. So I'm curious if you had discussions around either of those 2 points that are related, or even if you didn't have discussions around them, what your thoughts are.
Okay, well, first of all, very nice to meet you, albeit at a distance. I read your paper. I think very interesting. I like it. I like the way that you put things in perspective. And you mentioned very lightly about what most Anglo-Saxon, Canada is an exception, deal with all these things. They are very pragmatic. But the pragmatism is about other people, not about themselves, as you said. Very easy for me to be pragmatic because I'm protected. So I may say, well, we have to do that, but let's think about the suffering. I think that's Brazil. It's you have to come here and work with us. I hope sometimes you do, because here's a very good experience for all of us, medically and bioethically, to see how things are not working. So when we decided to, as I mentioned in my talk, when we decided to do this document, was first because of the pressure of this expectation that we are going to have a lot of death in the hospitals because we didn't have ICU beds. And then we discussed differently. So we don't have to get to that point. There's no need to get to that point. And I think this is the new thing about the epidemic, because we can discuss that more thoroughly. It's impossible to maintain things the way they are, because we're going just to repeat, people not get even the beginning of the treatment. So if they don't get the beginning of the treatment, when they get to the hospital, they're so sick. But maybe you say, no, you cannot save them. So we use the last point of the curve to justify things. So I think that's the main point of our discussion. I think we can talk a lot about that. And another thing that you mentioned, I have been fighting in many of these venues, including with Zach Emanuel, because usually we are in different positions, usually most of the times, especially research ethics, access post-trial, placebo use and things like that. And they like to say that they have universal agreement. It's not universal at all. Bioethics is not universal agreement. But most of the times it's USA-based universal things. And I have been fighting for that, even in documents. I'm participating now, as you know, in the International Bioethics Committee of UNESCO. And many times we're writing documents and they quote European documents. So, well, there's documents all over the world. Why are we going to use just the European? So that's the point, that we have to be together and fight all the time to discuss that. And the randomization, that we call it a lottery. Some people said that. In the end, you just put numbers. We didn't put that in our document. And luckily, when you see the flow chart, we used what the Brazilian Society of Intensive Medicine decided to use, and we thought was very good because they are exactly on the medical side. They use bioethic things, but the way that they put the last decision, if we need to decide, randomization was not included. And I think it's a point that maybe we are going to face that. I don't think now we are going to face that at this moment, especially now in Brazil, that luckily things are going a little bit down, where we have space in the ICU, and people tend to forget, say everything is resolved. It's not resolved because it may happen another epidemic. And we have been having that. We had that with when the HIV started here. People were not able to access hospitals because people were afraid of getting those people living with HIV. So we have experience on that, and I think we have to be fighting. When I mentioned about emancipation, of course, that's very hard to do because people have to emancipate themselves. But we can do, like you and I, we can be a discordant voice. And I think that may be the thing we have been doing in Brazil all the time, especially maybe you don't know much about what's happening here, but we're living in a barbarian situation with the government. I may say that it's a recording, but I'll be bold enough to say our president is worse than the North American president. So it's a situation that's very hard, but I think we have to resist. And just to finish, of course, with my time of life, I was finishing medical school when the military dictatorship was in their worst part. So we had that before. So we hope that's going to be over again. I don't know how long it's going to take, but I think we agree with most of the things, and we think that vulnerability has to be the main point when we talk about that. When you say, who is going to need access? I don't think it's not any of us that are in these 25 people here. We are going to have anything we need, no matter what place you are, because we are people that are different from the most vulnerable population in this world. So I hope that I was not too long without answering the first question that you made, but hope that we can discuss more of that. And again, I enjoyed very much reading. It was a good reading if you compare with the other paper that Chieko sent, that was written exactly by Ezekiel Emmanuel and et al. So thank you very much. But just a curiosity, where are you now? In what's the city?
So I'm in Halifax, Nova Scotia, and that's on the east coast of Canada.
Yes, I know where it is, yes.
An isolated region, so actually right now we've had no community transmission for weeks. We're very safest place in the world to live, if you can have an excuse to move here right now.
Yeah, thank you very much. So Domenico, hello. He's coming from Italy.
Yes, I was able to join. He had some difficulty, but I really appreciate it very much. The discussion, it's a very interesting topic indeed.
Yeah. Well, from after 9 o'clock, sorry, not 9 o'clock in Italy. So we are now in the second part of discussion session, and we are now discussing about the resource allocation issue, and Italy is a very severe situation. And I sent Professor Greco some text of the paper by Ezekiel Emmanuel. I wanted to ask Professor Greco whether or not this argument that this is a matter of course in United States, that removing a patient from a ventilator or ICU bed to provide it to others in need is also justifiable. He says that. And also, many guidelines agree that the decision to withdraw a scarce resource to save others is not an act of killing and does not require the patient consent. So this is very difficult for the agreement in the society. I think that I know very well that there is some kind of agreement in United States, but how is it in, I would like to ask Professor Greco, how is it in Brazil? And also I wish to ask Domenico, the situation in Italy.
Okay, we could start with Domenico. Ciao Domenico, piacere.
You know him.
It's a real pleasure being with you, and really I enjoy very much this discussion. But of course, I will appreciate first to hear from you the Brazil situation, because indeed we don't have very much news about Brazil. You know, sometimes your medical journalists are more concentrated on the local news, also because the general public is more interested in the local situation rather than to have a global picture. However, I believe that since our task, our job is global from the very beginning, I think all of us, I presume, are very curious about other countries, maybe some intervention that you are considering, some ideas that are being discussed. So if you can start, that will be very much appreciated.
The question that, molto piacere di sentirti. The question that Chieko made, and it's written in this paper from Ezequiel Emanuel et al., it's, they're very pragmatic about things, about other people, of course. And maybe that would happen in the United States, but I don't think that would ever happen in a country like ours, in Brazil. And I don't know, maybe Italy had to deal with that because you, at one time of the epidemic, you had so many patients in hospitals that people had to make decisions. But I'm not sure, and I expect it did not happen, that people take someone out of bed to give to someone else, because many of these times we don't know what's going to happen if we keep that one who's going to survive, maybe if he stay a little bit longer. One thing that people are doing and talking about, and I think that's happening in Italy, like it's happening in Brazil, and that's one of the reasons that I say to my patients that I'm an infectious disease person, so I have a lot of patients that call me and ask about things, and even the reporters, they want to know things. One thing I say is that with the development of the pandemic, our professionals, especially the intensivists, are much better qualified now to face things. And people, many of the mortality at the beginning of the epidemic was very high. And Italy was an example. And we used that as an example because we learned a lot of things from you. Many of the things that people did in the beginning should be done differently. You start doing differently. We have been doing in Brazil. So mortality in hospital had gone down. So responding directly to Chieko, I don't think that in Brazil this would not go through. If we say that even without asking people, we're going to take people from the respirator to give to someone else. I go back to my point that I discussed with Lynette. I think that now we have the possibility, and Italy now that's going to face the second wave, to make the diagnosis much earlier, to treat people much before they need to get to the hospital to be in the ICU. So we have to discuss in that direction instead of trying to make decisions at the end of life. And I forgot to mention something that Lynette said, that we have experience with other conditions. that happened with HIV/AIDS, we never thought about deciding who is going to be accepted, who is going to be medicated. Everyone gets that. And we have experience with giving vaccine for influenza. We choose first the elder. So that exactly the people that theoretically have less time to live. So I think, answering to you, no, it would not pass, I think, through our revision in Brazilian bioethic evaluation.
Well, first of all, I was very pleased to hear you, Professor Greco, saying a few words in Italian. So it's a real pleasure that our Latin origin allow us to exchange in our original language. I fully agree with what you say. I can add just a few things about the situation in Italy. You certainly are familiar with the fact that we were, after China, the first Western country to be hit by the infection, which very likely arrived in Italy in December last year. The reason is that the area around Milano is made of several companies, several small companies that run a lot of business with China. So there is a lot of people traveling to China, coming back, and it's very likely that one person, one manager of a company making business with China that was in the Wuhan area in December brought the infection very quickly into the area around Milano. So we were terribly hit by the infection, also because we were unprepared. And you know that we had a very high number of infected people. But the critical issue, as you say, is that most of these people arrive at the hospital very late. Yeah. So we had a significant number of deaths because these people had not the possibility to get an early diagnosis and an early therapy. In addition, there was a lot of confusion about the best therapy. You know, there were a lot of discussion about chloroquine. Even at the beginning, some clinicians recommended not to use steroids because there was the idea that they will diffuse more and more the infection. Now we know that the dexamethasone is one of the best therapy that we can have. But luckily, after 2 months of crisis, that was mainly March and April, we entered the summer season. What I really wish will happen also now in Brazil, that is moving to springtime and summertime. And this is a respiratory virus, so the viral load is going to decline. So I hope that Brazil will get the benefit from the summertime that is approaching. We had indeed a very low number of cases in summertime, but unfortunately people, especially young people, considered that the infection was completed, was finished. And so we had a lot of people going to the beaches, to the disco, and this created an environment in which the virus was still disseminating. And then with the first cold days of September, the infection is spreading again. Now we are moving at a very critical number of about between 10 and 15,000 new cases per day, which is very high as compared to only 1,000 of 2 months ago only. However, there are some difference between October and March. In March, people, as I told, went to the hospital very late, and most of them had to go to the emergency unit care, being intubated and so on. Now, people go to the hospital very early, Some of them are even recommended to stay at home because they don't have the need to be in hospital. They simply stay at home without symptoms, waiting for the negativization of the oral tampon. But the situation, let's say, is still critical also because we are entering the winter season, especially in the area of Milano. Today it's a terrible day, rainy, cold, and this is going to last all November, all December. So in fact, now the recommendation is to stay at home as long as possible. We are not in a lockdown situation like in March, April, but the recommendation of our authorities, especially to elderly people like me, is to stay at home as long as possible, avoid the useless wandering about, and also we have a lockdown at night. All people must stay at home between 11 p.m. and 5 a.m. in the morning, unless there is a very clear medical justification. So this is a measure that was enforced already a couple of days ago. So we have to see if this will produce some benefit or not. We try to keep school open because this is a must. We had already a critical situation with our children at school from February, March until June. So we cannot lose another year for our children. Also because in many cases, both parents of these school children are working. So if schools are going to close down, there is a critical situation. Anyhow, most companies are now coming back to working from home. And so in short, I want to conclude here, the situation is still critical. We must pay attention. The virus is still with us. The situation is different. We have almost 1 year experience with this virus, but we need to be patient, in my opinion, at least for the next 2 months. It's difficult that a vaccine will be available in millions of doses, because it's not only to get a vaccine, but to get millions of doses and to inject the vaccine to millions of people. So you cannot do it in the weekend. So it's a matter of months, and we know, we work in the pharmaceutical industry, we know that producing millions of vials, because these are not tablets that can be produced very quickly. These are vials, and the machine producing vials have a limited speed. They are not, they cannot produce thousands or millions of doses in a few days. So, in short, we need to be careful, trying to maintain key activities open and trying to avoid all possible occasions that will facilitate the contacts and the dissemination of the virus. And that's all. Thank you for your attention.
It's very interesting to hear that from you, because we're facing that too. We didn't finish the first wave, so we still have a lot of cases, a little bit less, and maybe weather is going to help a little. But another thing that happened in Italy, and that we used it, is that, for instance, people were put in respirators very early, and they found out that that's not good. Many people died because of that. Now they know that we need some time to decide that, so that's another good thing. And the other most important, I think, that both of us mentioned, is related to the diagnosis that should be very early. And the second point important is that by doing one diagnosis, you are be able to get the cluster. So you can test everyone that was in contact, and you isolate in a good way those people. So maybe that's a way of doing. We have a problem that you don't have, but you still have a little bit, especially if you go to the south of Italy, because we had a lot of people that don't have what to do when they stay at home. They don't have salaries, they don't have money, they don't have food. So that's another thing that maybe Lynette and I and you may fight together with Chieko to have the universal what's the name? Universal money for everyone. Every month you receive some money. There's a word for that, I forgot it. But that's a thing that we have to discuss now again. Because if we don't do that, even if we go through this, and I agree with you, the vaccine is not going to be a magic bullet, and it's not going to be available in that amount of numbers. They have to be produced, put in vial, you need syringes, you need people to have it, and you don't know if you have to have 1 or 2 doses. So it's a problem. And I get back to Chieko.
So thank you very much. So if it is possible, I would like to ask a comment. Kyoko, is it possible? Because she met Professor Greco last December. Kyoko?
Hi, Dr. Greco.
Hi, how are you?
Nice to meet you again. Yeah, fine, thank you. Well, and thank you for your nice presentation. And since the situation is very different here in Japan, so I have no idea where to start. But I find the recommendation a number of good things described and well tabulated, but it's again it's not the legally binding document or anything like that. So there must be many difficulties to implement in among the chaotic situation. But what would be the strategy to make everyone follow your recommendation?
That's nice. Nice to see you. Thanks very much. That's what the Anglo-Saxons call the $500 million question. I think that's the problem. I think I'm just quoting again Bobbio, my compatriot from Italy, that now he has a son that's working in the same direction. But the point is that we don't have a way of making it binding. Mm-hmm. The only way we can do, and that's what we decided, was to spread the word. We have now a document saying that that should be the way that should be done. So people can use it. And I'm hoping that this may be a counterpoint to the barbarian situation that we're living here. And I think that may happen in many countries, even in parts of Canada, in parts of Japan, where more poor people are. You need something that say, look, there's a document. And this happened with research ethics, people using what is written on the informed consent to ask for what they are entitled to. It's not binding, but people can do it. So I agree with you. It's a hard way. It's a slope that's difficult to go through the end of it, but I think that's the beginning. Mm-hmm. And in a way, I think all of us, you work a lot for many years doing what you do in a very good way. Chieko is doing all the time. We have to be part of this discordant voice that is still not too many people using it, but I know it would be nice to have it enforced. So look, make what we did. Let me finish just with that. A group of institutions and entities, and the Brazilian Society of Bioethics is one of them. We made a document. It's a plan, a big plan to confront the epidemic. Of course, it's not binding. It's 70 pages long. What are we doing? We went to the court, showed it to them. We went to the politicians and share with them, and we have been spreading it all over to say, look, we have things to do. So it's written. There are entities that are well seen by the population. Let's go and use it. But it's difficult. I think it's going to be hard, but we have to keep fighting for that. Thank you for the good question, easy question to answer.
Yes, that's also the point I wanted to ask him. So how does Sander, can you participate? He's a chair of our ethics working group of IFAP. Sander, is it possible?
Yes, I try. Do you hear me?
Yeah.
No.
Please give me a question, anything.
What I wanted to comment is that it's a very interesting during the second wave. The second wave, Europe is hit very hard, and it is partly because Europe changed its approach to the disease. The first part, we tried to control the disease. Now we try to control the national economics. And in a way, we do not close the companies, we do not close the cultural places, we make most of the restrictions only voluntary. And what is happening, we only try to say at least that we are saving the elderly population. However, the elderly population becomes now totally isolated from the society in order to save itself, if it can. And the second part, an enormous number of young people become infected, and the infection spread enormously rapidly. And I think this is a very interesting ethical attitude to the society. You can put it in a different way. In order to save the economy, the elderly population is left practically alone and is practically left there to be infected by the people who have to go to work, whom all the possibility is there to go to the cultural organization to get infected. And we see the large number of infected people. And everybody knew that the next step will be that the elderly population will be infected. And now we began to see in the second step that the elderly population becomes again seriously infected, that the largest number of people will die. So it is a very difficult ethical attitude now we have to go so into the society during the second wave in order to keep up the functioning of the economy. And this is, I think, a major ethical problem which the entire society is confronted with. I don't know what is your opinion and how do you see that in Italy and in Brazil?
Yeah, that's a very good point. And how can we decide about it? But it's happening in Brazil too. They open everything. They had decided that
we do the same thing.
Yeah, it's has been open in many places. And I see my city. It's a big city, 3 million people. I go to places by car and I see people everywhere. They're just like nothing was happening. And of course, many of them are young people that may think, and that's another fake news, that's not a problem for them. And we know that maybe 35% of very severe disease occurs before you are 50 years of age. So we're facing a problem that we don't know how.
I agree with you. We see let's a large number of people get infected, much more than we had before. We see that the younger generations, there is a given percentage of the younger generation who has some kind of weakness, possibly immunological weakness, who get very seriously sick, and either dying or having a very long disease, post-infection problem and symptoms. And finally, I am afraid we will have a large decrease of the working force. We are leaving them into that to keep up the society, but it might be that the end, not only the elderly, but also the younger people we will decrease the working force because they will get out of work or they will simply die out. So it's a very serious problem, and this overemphasizing keeping up the normal function of the society and the economic life. This is, for me, one of the ethical problems which I see nowadays as a major problem coming up in our society.
Yeah, that may be an opportunity also. I forgot the name at that time, that to establish universal basic income. Because if you think most of these people are not going to be able to work for a long time, and maybe in Europe, it happened in Brazil, the richest people in the country got richer because there was opportunity for everything, to buy things very cheap, to use the banks and things. So maybe that's the time that we all together have to fight. And I think that was happening in Europe for some time ago to try to have universal basic income to everyone. But I think that's the time for it. Maybe with this, we can maybe use, first of all, lower the impact of the social determinants. So people are going to be treated much before they are now. And maybe we can keep the economy in a way going on, even with this pandemic. And let us all think that when the pandemic goes away, all the other diseases are still there. Obesity, diabetes, asthma, for us, many of the infectious diseases, HIV, they're all there waiting for us. So that's going to be a problem that we have to deal with.
They do not disappear, unfortunately.
That's right. They are not substituted. That's the problem.
No.
Thank you, Sandor.
Thank you for your interesting lecture. I really appreciate it.
Thank you.
Thank you very much. So I would like to have one question. And at the last part, I'd like to ask Eisuke Nakazawa to have some kind of closing remark, or if you like, please ask a question or a comment or something like that. So one question I would like to ask you is that how the Hospital Ethics Committee works in Brazil. You said that only a first time meeting would be held next October. And I think that your algorithm written in your recommendation is excellent, but it is very difficult to implement. But the Hospital Ethics Committee has a very important role to implement this kind of resource allocation or a very difficult decision making. How is it in Brazil?
Yeah, you're completely right. I think what we did when we finished the recommendation was not just to take a bunch of bioethicists and decide what's going to happen in the ICU. So we associated, not really associate, but we use what the intensivist people in Brazil decided to do in a way that can be applied even if you don't have a well-established bioethics commission in the hospital. But in the same aspect, we decided not only to expand the possibility of having many hospitals. They are now concentrated, most of the bioethics committees are concentrated in the southeast of Brazil, especially São Paulo. That's the largest place where they have most hospitals. But we have even one of our vice presidents of the Brazilian Society of Bioethics was the one that brought to us the possibility of having the first national meeting to discuss that. It's a little bit late, but I think it's a good start for a problem that we are all going to have to face. We are facing it even without the commission because everything is happening today in these hospitals. So people are doing it, not well established as a commission, but maybe this push that we're going to do may help them to spread that and have more committees throughout the country. How is it in Japan?
Yeah, some of the hospital have such kind of hospital ethics committee, but there is no any guidelines from the government or even from the Bioethics Association. So there is no any organization. I think it is very important to have some kind of organizational activity to discuss about this kind of things or hold the nation. And if there is some kind of governmental instrument, it would be effective, I think. So yeah, I think Professor Nakazawa is very much have the expertise on this kind of matter. So could you give us some kind of a comment or question or closing remarks or something like that?
Okay, thank you very much, Jacob, and thank you very much for a nice talk, Professor Greco, and now everyone who participated in this very fantastic workshop. I think I'm concerning about the after effect of COVID-19. Because COVID-19 is, of course, an infectious disease, but at the same time, the COVID-19 is a disease of imparity and disease of distrust and disease of isolation. I realize that today again. Then, especially in Japan, some news broadcasts said that solitary death in elder generation and suicides in younger generation is increased in Japan. I think it's a severe problem or the after effect of the COVID-19 in Japan. And we will confront on the severe after effect in the near future. We will collaborate each other. International collaborate is needed. From the viewpoint of that, we can continue the discussion for the world happiness and collaboration of international cooperation in the near future. Thank you very much for your nice presentation, Professor Greco. Thank you very much.
Thank you, Donaka-san. I hope we can keep this collaboration between the two societies.
Of course,
and of course, what we're going to have in next October, we hope to have much more committees we can discuss on that. And I think I can share with you, Chieko, Takeo, and myself, we're very close now, even with the distance, so we can keep talking, including Lynette. And there was a good comment from the audience. Varvara Barutsu said that public health is a prerequisite for a strong economy. And I agree completely. I think if we don't save the people, we don't care about the economy. I think we have to save people. And by saving people, we're going to have a stronger economy. So not the other way around. People think that the other way around. So we have to have a strong economy. And this has been happening a long time. People say we have to make a big cake before we decide to split it. I think it's the other way around. And maybe that's the after pandemic, that maybe we have a window of opportunity. Because when you say that it's needed international participation, that's very hard to have. Even remember, Domenico mentioned, what do Italy know about Brazil, even having here the largest Italian community in the world outside of Italy? There's no way, we don't communicate, we don't have, you have your own problems. I think we have to be certain of that, use these opportunities for all of us together to make the word spread. If we don't save all of us, like Gasset mentioned, I myself and my surrounding. If I don't save my surrounding, I will not save myself. So maybe that's the way we should proceed from now. And I know that we don't have much time, but I'm just repeating what I said at the beginning. I'm honored to be part of this first long distance debate. And I enjoyed very much seeing some of the old friends and getting to know other people. Thank you again, Chieko, for this very nice discussion, especially thinking that now it's 11 p.m. in Japan.
Yeah.
Thank you very much.
So thank you very much. Thank you indeed. So Dr. Lynette Reid left a little bit earlier, but she also said that in the chat that she wished to keep this kind of collaboration. So thank you very much. So thank you everyone for participation. We will have the next session, part 2. We are planning to discuss about clinical trial ethics. And after that, we wish to continue more and more to collaborate this kind of ethics and COVID-19. So thank you very much for all of you for your participation. Bye-bye.
Thank you very much. Thank you. Bye-bye.
Bye.
Good morning, good afternoon, good night.